Good morning, everybody. First of all, let me thank Dr. Samyukta and KSOS for giving me this opportunity to present this very interesting topic in front of my mentor, Dr. Meenakshi Madam. So today I would be discussing about identification and characterization of DVD. So as you can see, dissociated vertical deviation is a tendency of the eye to intermittently elevate, abduct, and excyclotort that can occur either spontaneously or when fusion is broken by occluding one eye. So there are basically three components that are involved in DVD. It is not a single deviation, it is an elevation, excyclotorsion, as well as an abduction. So when this eye comes back to the normal position, you expect the other eye to depress. But that is where this deviation becomes very unique. DVD violates the Hering's law of equal innovation. You do not see that refixation movement downwards in the other eye. There is no movement seen in the contralateral eye as the uncovered eye takes up fixation. So it was first of all introduced in 1895 by Stevens. There has been many names to it, but the most popular one that we are using routinely is the dissociated vertical deviation, which was by Belchovsky in 1938. But a more comprehensive name would be a dissociated strabismus complex, because it is not only the vertical deviation that is there, you also have a torsional and a horizontal deviation, which is of equal importance in this particular one. So what are the clinical features? How does the patient present to you? The patient is usually asymptomatic because of poor fusion and suppression. DVD is usually bilateral, but it is very asymmetric. It can be latent, but can also be manifest, intermittent and manifest with variable magnitude, more commonly seen after the first year of life, and the most common association is infantile esotropia. It is usually present by 2 years, whether or not the underlying strabismus is surgically corrected. Latent nystagmus can also be there, horizontal incompetence can sometimes be there, and abnormal head posture, and DVD is more manifest at distance than at near fixation. So how do we classify DVD? DVD can be latent or it can be manifest. Manifest means it spontaneously occurs, whereas in latent you need to dissociate the fusion in order to manifest that. Depending upon the amount of deviation in primary position, abduction and adduction, you can classify it at committant DVD and incommittant DVD. In a committant DVD, the deviation is within 7 prism diopters in primary position, abduction and elevation. Whereas if it is more than that, it is called as an incommittant. Also based on the degree of the deviation, it is mild when it is less than 10 prism diopters, moderate when it is less than 20 prism diopters, and large when it is more than 20 prism diopters. So it may not be easy to measure the DVD in infants and uncooperative patients. Then you have to grade them in a scale of 1 to 4 depending upon. In grade 1, it is a very small angle with excellent control. Grade 2 is a small angle with poorer control, which is very tropic with several covers. And grade 3 is a poorly controlled DVD, and grade 4 is a manifest that is more than 15 prism diopters. The most common association of dissociated vertical deviation is, of course, infantile esotropia, and it is seen in about 75% of patients with infantile esotropia. But it can also be seen in cases of congenital exotropia, nystagmus, accommodative esotropia, and there is a particular syndrome that is called as Helveston syndrome, where you have got A-pattern exotropia, bilateral superior oblique overaction, and DVD. In infantile esotropia, it is said to be there in about 90% of patients with infantile esotropia. It can develop DVD. Now, the clinical importance is that if you do a surgery for infantile esotropia less than 1 year, it is important to inform the parents that there is always a chance of development of a second deviation, which is unrelated to the surgery that you have done, because DVD usually presents by 1.5 to 2 years. Another predictor factor for DVD is an asymmetry in the rotating OK drum. DVD, although not very common, can also be seen in intermittent exotropia also. But it is seen in those cases which have an earlier onset of strabismus, worse binocular visual function, and also, unlike in infantile esotropia, DVD in IXT was smaller in amount and demonstrated a more uniform response to Belchovsky's head tilt test. It can also be seen in sensory exotropia. Anomalous head posture is seen in 35% of the patients, and it is said to minimize the magnitude of DVD and to control the nystagmus, and it is a direct tilt when the head is tilted to the fixing eye and inverse tilt when it is tilted to the non-fixing eye. Now, measurement of DVD is a very challenging topic which will be dealt with by Dr. Samyukta. Dr. Arthur L. Rosenbaum, who is a very well-known strabismologist, said that measuring DVD poses a challenge even to the astute clinicians, and these are the various tests that will be used for that. I would be mainly focusing on the differential diagnosis of DVD. So what are the DDs of DVD? It can mimic a hypertropia, a true hypertropia. So this is a patient with a left superior oblique palsy with a left hypertropia. So you can see that the left eye is hypertropic under the cover, and then when the left eye takes a fixation, the right eye moves downwards. So that is the typical characteristic of a true hypertropia. But when you see a patient with dissociated vertical deviation, the left eye is moving from up to down, the right eye is also paradoxically moving from up to down because this is a case of bilateral DVD. Whereas in a true hypertropia, you expect the movement of the right eye from down to up. So with that, you can identify whether it is a true hypertropia or a dissociated vertical deviation. Now, another clause called is that of an inferior oblique overaction. So this is a child with bilateral inferior oblique overaction. So you characteristically find that the elevation is more in adduction because it is being an inferior oblique overaction, whereas in DVD, the elevation can be present in primary position, abduction, as well as in adduction. So you can see that the inferior oblique is overacting, and correspondingly there is an underaction of the superior oblique in case of inferior oblique overaction. And the contralateral superior rectus is also underacting. And the pattern that you get in inferior oblique overaction is a V pattern, unlike in case of DVD. So these are the differences summed up together. So the refixation movement in a DVD is a slow and downward and inward movement, which is very slow, whereas inferior oblique overaction is a characteristically fast movement. A V pattern is absent in DVD. Superior oblique overaction can be present in DVD. Then encycloadduction is present in DVD, and latent nystagmus is usually present. And two tests which helps you to differentiate the two Bolshevsky and red glass test will be dealt with by Dr. Samyukta. Now, the third one is a Heman-Bolshevsky's phenomenon, which is seen in patients with severe vision loss in one particular eye. So there is a slow pendular vertical oscillations of the eye, and in the eye with severe vision loss due to disruption of the fusional vergence mechanism, you see this particular condition. So vertical eye oscillations can occur from below to the horizontal and to above the midline. So all this can be a different close differential diagnosis of DVD, but when you find the characteristic absence of the refixation movement, you will be able to identify that. So thank you all for the patient listening.